Hello and welcome to the VJHemOnc podcast. Today we're shining a spotlight on one of the most challenging areas in acute myeloid leukemia, treating patients who are elderly or unfit for intensive therapy. These patient populations often face limited options, but the treatment landscape is rapidly evolving. So, what is currently considered the standard frontline approach for elderly or unfit patients? Farhad Ravandi will speak first on the use of hypomethylating agents in combination with venetoclax as the go-to regimen in these patients.
I think there is now plenty of data that the combination of hypomethylating agents plus venetoclax is very tolerable and effective in these older unfit patients. I think that is clearly the current standard. And as I mentioned, with the introduction of an all-oral version of this, it may be making life a lot easier for these patients. Now, I am a strong believer that the initial induction should be carefully monitored, and I actually believe that most patients should be hospitalized, although I believe that community oncologists may not adhere to this practice. But I think any AML patient, particularly patients who have other comorbidities, do need some degree of supervision during the first cycle of therapy. That much more that becomes much less closely watched in the subsequent cycles. I think the other debate will continue to be the number of days of venetoclax that's needed for such regimens. The French study suggested maybe only 7 days of venetoclax would be as good, although if we look at the subsets of AML patients, it does appear that patients with certain molecular features, such as those with NPM1 or IDH mutations, do benefit from more protracted dosing of venetoclax in the first and subsequent cycles. So I think, like everything else that is going on in AML therapy and cancer therapy in general, I think we have to use a personalized approach for each patient and design the regimen based on the patient's features. So, for example, in patients who have P53 mutated AML, I do believe that there is still a role for venetoclax, but is not as important as in other subsets. But I think the addition of venetoclax, even in P53 mutated patients, to azacitidine or decitabine, does improve the response rate. So if there is a potential for an allogeneic stem cell transplant, I still do believe that there is a role for induction addition of venetoclax in such regimens. Another regimen that has been extensively used at MD Anderson and is now being used in other places is the cladribine, low-dose cytarabine plus venetoclax, which is also very effective in this population. Finally, I think we are beginning to develop triplet regimens, and this is being very exciting development, in my opinion. Traditionally, in cancer therapy, we have believed that a combination of several agents is more effective in reducing the risk of resistance in cancer patients and in leukemia patients in particular. So I think addition of agents to the backbone is necessary. However, we do have to do this very carefully because there is potential for increased toxicity. And of course, these regimens have to be well designed to try to avoid losing any benefit from the increased toxicity.
While venetoclax-based combinations have become the standard, researchers are exploring ways to further optimize outcomes. Next, Gail Roboz shares insights into triplet therapy strategies that build on the HMA venetoclax backbone by incorporating targeted agents based on the patient's mutational profile. Marina Konopleva then further comments on the use of targeted agents and triplet therapies in older or unfit patients.
A hot topic at the meeting was how to do better in AML. So how do you get deeper remissions faster? And how do we cure more patients? So I would say an emerging discussion, both for patients who don't currently have curative options, so older patients who aren't going on to transplant, But also for younger patients who are on a curative path is what about triplet therapy, or what about adding in agents to existing backbones? So this is a very hot topic. And the question is that, for example, if you have a combination therapy, let's say, of a hypomethylating agent and venetoclax, but you have an IDH mutation, should we be adding an IDH inhibitor on top of that? This is not standard of care. These are in clinical trials, but the MD Anderson Cancer Center, for example, has led efforts in IDH1 mutated patients to have a combination of a hypomethylating agent, an IDH1 inhibitor, and venetoclax. In FLT3 mutated patients, also led by MD Anderson, preliminary data looking very promising for a hypomethylating agent plus venetoclax plus gilteritinib for FLT3 mutated patients. And these are moving into the randomized trial setting so that we can finally actually learn who do we need to do this for, and from a survival perspective, are we actually prolonging survival? Are we getting closer to curing those patients, or are we just layering in additional medication?
It depends whether the patient is getting therapy in the setting of clinical trial or in the setting of off-trial therapy. So at our institution, we have two frontline clinical trials. One is for younger fit patients, which is combination of 7+3 plus venetoclax BCL2 inhibitor. The data were just published in Blood last December, and the initial cohort of about 38 patients, the data look very impressive. With a very high response rate, above 90%, and MRD negative rates about 80%. So it looks in non-randomized fashion much better than historical data with 7+3 alone. So this study has expanded and is ongoing and has been our frontline therapy for the younger patients. With that said, we realized that there are certain targeted therapies that can be also highly beneficial. For example, menin inhibitors have been presented at this meeting to be highly effective in NPM1 mutated and KMT2A mutated rearranged AML in the frontline. So we're part of some clinical trials that investigate that. Also, for patients with FLT3 ITD mutations, so we do add the FLT3 inhibitors usually in the consolidation setting. So as far as older patients, again, the second clinical program that has been developed at Montefiore is what we call metronomic therapy, that is utilizing very low doses of weekly decitabine and weekly use of venetoclax. So it's really like a fraction of the standard of care dosing. It's metronomic, so it's slow working therapy. So usually it takes about 3 months before patients actually get hematologic recovery and go into remission. But we feel that this is like highly effective therapy, and it allows patients to get it outpatient with much lower readmission rates and less transfusions and less infections. So we've been working on this trial now for quite some time, and there's also like initial data have been reported. It's also effective in the setting of FLT3 mutated AML that don't do well with traditional dosing. So, but we realize that this is not a curative therapy, so we're moving with the field towards the triplet therapy. So we are developing what we call basket approach, where we're adding targeted agents to this backbone. And we think that this is perhaps better backbone than the standard dosing of HMA-VEN, because it has a room for myelosuppression, so it's not as myelosuppressive as the standard therapy. Therefore, we are adding the IDH inhibitors, FLT3 inhibitors, eventually menin inhibitors to this backbone, and hopefully we'll get better results for our patients.
As Professor Konopleva mentioned, there are investigations into menin inhibitors in this patient population. Joshua Zeidner speaks next on the results from the BEAT AML consortium, which investigated the combination of azacitidine, venetoclax, and revumenib in newly diagnosed older adults with AML harboring NPM1 mutations or KMT2A rearrangements.
So we designed the phase 1b study of azacitidine, venetoclax, and the addition of an investigational menin inhibitor, revumenib, to the backbone of standard frontline aza-ven for newly diagnosed older unfit patients with an NPM1 mutation or a KMT2A rearrangement. I think there's several findings from our study that we presented on Thursday at the European Hematology Association Congress, and this is now subsequently published in the Journal of Clinical Oncology. The first notable finding is that it was safe. to escalate revumenib at both dose levels. We started at dose level 1, escalated to dose level 2, did not see any dose-limiting toxicities. The regimen was overall safe and feasible to administer in this population. The second important finding, of course, is that this was a highly active regimen. We saw complete remission rates of 67%, overall response rates in the 88 to 90% range. And this was in both NPM1 mutated patients as well as KMT2A rearrangements. Our overall survival analysis is a bit short with follow-up, and we're still analyzing our data of the 43 patient cohort that we've enrolled so far. But the results are incredibly exciting to us and has led to the design and development of a randomized phase 3 study known as EVOLVE-2. And this is going to be comparing azacitidine, venetoclax, and revumenib versus azacitidine, venetoclax, and placebo in this newly diagnosed older unfit population with an NPM1 mutation or a KMT2A rearrangement. We hope that these results will, be practice changing and can change the standard of care for this population. We're interested in obviously having further follow-up of patients on this study, and we're enrolling more patients to really fully determine, which patient subsets, might really benefit from this regimen and what are the mechanisms of resistance and relapse that can happen after patients achieve a response on this regimen.
Is stem cell transplantation a viable option for older or unfit AML patients? Next, Nelli Bejanyan weighs in on what factors to consider when evaluating transplant eligibility in this population. This is followed by Parastoo Dahi, who further comments on assessing the eligibility of older adults for transplant or cellular therapy.
Unfortunately, not all older patients are candidates for allogeneic transplantation. We have safer platforms available nowadays, both from standpoint of conditioning regimens as well as GVHD prophylaxis, such as PTCY-based GVHD prophylaxis has revolutionized how we approach to patients with low risk of non-relapse mortality. So, however, this is still not therapy for everyone. We take into account comorbidities that are present at the time of transplantation, as well as the Karnofsky performance status from selection and patient factor standpoint. But also disease-relevant factors are important as well, such as patients who have high-risk genetic mutations, such as the one with TP53 mutation, for example, particularly if patients are MRD positive pre-transplant, we know that routine reduced intensity, even more so non-myeloablative conditioning regimen, is unlikely to provide curative therapy to these patients. So therefore, in each individual case, we need to look into more details in terms of disease-relevant factors, transplant-relevant factors, and more importantly, patient-relevant factors as well.
Transplant and cellular therapy in general, I think, have been underutilized in older patients with blood cancer based on the perception that, older patients cannot tolerate these treatments. And this is one of the major barriers to referrals by community oncologists. But as we know, blood cancers such as lymphoma are primarily diseases of older patients. And given the significant prognostic impact of cellular therapies in younger patients and prospective studies, omitting this treatment based upon age alone could potentially affect survival in older patients. So with the advances in the field of transplant and cellular therapy, including the modifications in the preparative regimens and improving the supportive measures, we know that we can offer and extend these treatments to older patients safely. So when evaluating patients for cellular therapy, it's important to move beyond age as the only factor for determination of suitability and consider other factors such as physical function, cognitive function, comorbidities, and overall health of that person. And a tool that has been useful to identify vulnerabilities in older patients is geriatric assessment. This will potentially allow for not only identifying what are the impairments or where are the vulnerabilities, but can we actually do anything about them? So potential interventions such as exercise program or cognitive rehabilitation, etc., so that you improve their fitness prior to the cellular therapy. The published data do not support routine exclusion of older patients for transplant or cellular therapy, especially in the cases where there is a clear benefit to these treatments, and the vast majorities of, survival events have been disease progression rather than toxicities from the treatments.
To wrap up, we hear from Andrius Žučenka, who gives an excellent summary of how the treatment paradigm is evolving for patients unfit for standard chemotherapy.
So the treatment paradigm of patients who are actually unfit for standard intensive chemotherapy in acute myeloid leukemia field has changed dramatically. I mean, from the times when we only had low-dose cytarabine and hypomethylating agents, now we have the possibility to offer those patients effective and safe regimens. Of course, the most important of those is venetoclax and azacitidine, which was a landmark trial, a phase 3 randomized controlled trial, which proved that addition of venetoclax to standard azacitidine, a doublet, is actually producing high response rates up to 70% and offering prolonged survival of about 15 months at median. We also know that some genomic subgroups seem to do much better with venetoclax, such as IDH2 mutated patients. And of course, those who harbor TP53 mutations, unfortunately, are doing the worst. Nevertheless, currently, this is the standard of care for unfit, frail, newly diagnosed acute myeloid leukemia patients. And it's genomically agnostic. So this works for all genomic subgroups. Importantly, that after the AGILE trial, we now have another important treatment algorithm and option for our patients, especially those who have an IDH1 mutation, because now we can offer them the already approved therapy of ivosidenib and azacitidine doublet. So the response rates and the survival with ivosidenib and azacitidine for IDH1 mutated AML patients is really looking very promising. And the remissions are durable, and importantly, it's a safe therapy, which produces less myelotoxicity in comparison to venetoclax azacitidine. And this is something very important for our frail patients when we have a lower risk of developing a febrile neutropenia or a sepsis or a fungal infection. So this is something a very important part of thinking about and choosing the optimal therapy in those patients. Thirdly, we also have the possibility to offer those patients a smooth receptor blocking agent, which is glasdegib, in combination with low-dose cytarabine. That therapy is, of course, much less discussed and offered, but still, this is also an approved therapy, which we also have in our backbone. In terms of investigational therapies, I would like to mention the FLT3 inhibitors and their role in the unfit patient population. Currently, we don't have any FLT3 inhibitor approved for unfit frontline patients. However, the recent data and the data from the phase 2 trials are actually very encouraging. We see that the addition of FLT3 inhibitors, especially second-generation FLT3 inhibitors such as gilteritinib, are actually looking very promising in terms of very high efficacy when we add them to standard backbone of venetoclax and azacitidine, so a triplet regimen. Of course, the toxicity is also of highest importance because the combination, the triplets, at least with gilteritinib, seem to be quite myelosuppressive, and this is something to be concerned of, especially when we're talking about unfit, frail patients. Again, menin inhibitors are really changing the treatment paradigm, and they're moving strongly in the unfit frontline AML field as well. Early phase 1 data are actually suggesting that the response rates are very high, up to almost a 100% CR/CRP rates when we add a menin inhibitor, for example, revumenib, to standard HMA venetoclax backbone. And again, a menin inhibitor seems to be less myelosuppressive in comparison to second-generation FLT3 inhibitors. So this is also important that patients with NPM1 mutations and KMT2A rearrangements could be potentially treated with a triplet when we have a more mature data. I would also like to highlight that a lot of data and a lot of trials are actually trying to address the possibility of finding an optimal backbone to venetoclax. So we know that HMAs is the standard of backbone to venetoclax. However, the data from the phase 2 trials are actually showing that the possibility to use an alternative backbone with cladribine, low-dose cytarabine, and venetoclax alternated with HMA and venetoclax, so a treatment with an alternating manner, can actually produce very high response rates and durable remissions, again, in those less fit patients.
That brings us to the end of today's podcast. Thanks so much for tuning in. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.